Hello everyone. In this video, we will discuss selecting the most suitable functional appliance for correcting Class II malocclusions associated with mandibular deficiencies. Class II malocclusions can manifest in a variety of ways. It can be purely dentoalveolar or skeletal in nature, or a combination of both. A skeletal Class II malocclusion can be because of maxillary excess, mandibular deficiency, or a combination of both. If a Class II malocclusion is due to a retrognathic or deficient mandible, and the patient is in the peak pubertal growth spurt period, then a functional appliance should be used for the mandibular growth modulation. The objective of the functional appliance treatment is to reposition the glenoid fossa anteriorly and lengthen the mandible so that Class II skeletal relationship can be corrected. Thus, a functional appliance must be able to reposition the glenoid fossa anterior and lengthen the mandible for the effective correction of Class II skeletal malocclusion. In general, functional appliances are broadly divided into two categories. The first category includes removable functional appliances like activators, bionator, Frankel, and twin block appliances. The second category comprises so-called fixed functional appliances, which include Herbst appliances, Jasper jumpers, mandibular anterior repositioning appliances, or MARA, mandibular protraction appliances, or MPA, etc. Remember, all removable and the so-called fixed functional appliances can correct Class II dental relationships, but they may be ineffective in the glenoid fossa remodeling and mandibular lengthening. Thus, a functional appliance should not be selected randomly for the correction of all types of Class II malocclusions. While selecting an appropriate functional appliance, two factors must be considered. The first factor is what are the requirements for the patient. It includes whether skeletal changes are needed or simply dentoalveolar changes are sufficient for the Class II correction. The second factor is what are the expected effects of a particular functional appliance. This includes the degree of skeletal and dentoalveolar contributions of a functional appliance in the correction of Class II malocclusion. Literature suggests that the effects of removable functional appliances are primarily on the mandible. Their effects not only cause extramandibular growth, but also result in anterior repositioning of the glenoid fossa. Thus, these appliances must be selected for the correction of Class II malocclusions associated with mandibular retrusions. In contrast to removable functional appliances, the so-called fixed functional appliances primarily work on the maxilla. They work mainly by restraining the forward growth of the maxilla. In addition, they also induce distal movement of the maxillary and forward movement of the mandibular dentition. Thus, the so-called fixed functional appliances can be selected for patients who can tolerate greater dentoalveolar compensations for the correction of their Class II malocclusions. According to various studies, the skeletal contributions for the correction of Class II malocclusions are more by removable functional appliances compared to the so-called fixed functional appliances. Literature also suggests that the mandibular growth modulation by various removable functional appliances differs in magnitude. Among all removable functional appliances, the skeletal contribution for correcting Class II malocclusions is maximum with twin block appliance, followed by bionator, activator, and Frankel appliance. Thus, twin block should be the first choice for correcting Class II malocclusions due to mandibular deficiencies. A meta-analysis by Zimpadikas et al. in 2016 revealed that fixed functional appliances seem to be effective in improving Class II malocclusions in the short term, but their effects are mainly dentoalveolar in nature rather than skeletal. A study by Bastiani et al. Observed that both removable and fixed functional appliances had headgear-like effects, and were effective in the Class 2 correction. However, removable functional appliances had greater skeletal effects in Class 2 correction, and the fixed functional appliances promoted more labial movement of the mandibular incisors and molars. One more study by Nogueira et al. in 2022 also revealed that fixed functional appliances like forceps and mandibular anterior repositioning appliances effectively corrected the Class 2 malocclusions, but their effects were mainly by the dento-alveolar movement and maxillary growth restriction. Various studies also reveals that the skeletal contribution for the correction of Class 2 malocclusion was more with rigid-type fixed functional appliances compared to flexible-type fixed functional appliances. From this video, we can conclude that if skeletal improvements are needed to correct a Class 2 malocclusion, then a removable-type functional appliance should be the first choice, and the rigid-type fixed functional appliance should be the next choice. The flexible-type fixed functional appliance should be avoided to correct Class 2 malocclusions associated with mandibular deficiency. If a Class 2 malocclusion is dento-alveolar in nature and the patient can tolerate distal movement of maxillary and mesial movement of mandibular dentition, then a fixed functional appliance can be selected. Thank you for watching this video.